Is usually the consequence of long-standing, slowly developing pressure necrosis secondary to gallstone disease. It can sometimes develop following acute cholecystitis. And a path-obstructed sign on that small intestine-looking mat can only mean one thing: small bowel obstruction. If a large enough gallstone passes through a cholecystoenteric fistula, it can cause a mechanical small bowel obstruction, usually at the narrowest portion of the small bowel, the ileum. This is why most cases are referred to as gallstone ileus, even though it's technically a mechanical small bowel obstruction. Remember emphysematous cholecystitis? Well, it's kind of a complication and kind of a primary pathology. Another chicken and egg situation. On the one hand, emphysematous cholecystitis is highly associated with infection by gas-forming Clostridium species like Clostridium perfringens. On the other hand, gas in the gallbladder wall can be the result of ischemia and gangrene due to infection by the usual suspects E. coli or Klebsiella. However, Clostridium is a favorite of question writers. So be sure to make the connection between emphysematous cholecystitis and Clostridium infection. Okay, acute cholecystitis is what happens when the gallbladder gets all inflamed. But what happens when it's the bile ducts that get all hot and bothered? When biliary obstruction and inflammation occur within the major bile ducts, the resultant condition is known as cholangitis. To help you remember infection of the bile ducts, remember this candle tipped over, lighting up the main bocce court. Pro tip: infection of the biliary tree is often due to bacterial translocation from the intestines, hence the old term ascending cholangitis. Acute cholangitis is associated with three especially important clinical findings, all of which can be seen on this bocce ball banquet bell. Fever, hence the flame pattern decorative hat, right upper quadrant pain, as indicated by the pain lines radiating from the CSW, candle shot wound, and jaundice due to biliary obstruction, which can be seen, well, all over. The combination of these three findings is highly associated with acute cholangitis and is referred to as Charcot's triad, hence her short coat emblazoned with a triangle pattern. Keep in mind, however, that only half of patients with acute cholangitis present with all three findings of Charcot's triad. Because, well, not everybody reads the textbook. Womp womp. Acute cholangitis is caused by biliary obstruction. And the most common cause of that obstruction? A stone lodged in the common bile duct, also known as choledocholithiasis. Let this bocce ball gallstone next to Charcot remind you that choledocholithiasis is the most common cause of acute cholangitis. For more details on choledocholithiasis, head on over to our sketch on bile duct disease. Welp, turns out we're not quite done with the eponyms yet. If your patient with acute cholangitis has the findings of Charcot's triad, but in addition develops hypotension, represented by this passed out guy with a blood pressure cuff on his arm, and altered mental status, hence the creepy googly eyes and disheveled brain hat, you've got Raynaud's pentad. So we've tied the fever, right upper quadrant pain, jaundice, hypotension, and altered mental status all here with the pentagon pattern on his vest. Nailed it. Those two additional features of Raynaud's pentad might sound familiar. They're signs of sepsis. Acute suppurative cholangitis is commonly associated with septic shock, represented by this septic sewer lid complete with lightning bolts. Seriously, acute cholangitis is a medical emergency and always should be treated as such. We'll get into that in just a moment. Not surprisingly, leukocytosis is a prominent feature of acute cholangitis. So, more creepy guys in white bird masks throwing a ball onto the main court. Wait your turn, sir. Due to biliary obstruction, acute cholangitis also causes a cholestatic pattern of lab findings, including elevated total and direct bilirubin, hence the yellowish goat mask and his collar-like necklace, elevated alkaline phosphatase, represented by the box of ALK chalk, and elevated GGT, represented by our recurring GGT gadget knife. In some cases, acute cholangitis can result in liver abscess formation and hepatocyte injury. This, in turn, causes elevated levels of AST and ALT, shown here with those raised malt glasses. And to help you remember liver abscess, check out that hat. Looks like a liver, but with his angry red mask covering. Remember, acute cholangitis typically does not present with liver abscess or hepatocellular injury. In fact, a lack of hepatocellular injury helps differentiate it from other primary liver pathologies. Your history, physical exam, and a few routine labs should all but cinch the diagnosis of acute cholangitis. When you do suspect acute cholangitis, your next step should be to get some imaging. So, up periscope. The ERCP periscope, that is. ERCP is the imaging and interventional modality of choice for acute cholangitis. ERCP serves two functions. First, like this guy looking through the periscope, ERCP provides direct visualization of the biliary tree, which allows you to diagnose an obstruction. Second, a catheter, like this ball grabber, can be passed through the scope to expand the common bile duct outlet, aka sphincterotomy, and pull out the obstructing stone. But more on that in a moment. If the diagnosis isn't straightforward, say jaundice isn't too bad, there's no fever, the white count isn't super high, or they just don't look that sick, your typical biliary imaging modalities may be performed to help support the diagnosis. This includes abdominal ultrasound, represented by this dude's bullhorn, or MRCP, represented by the magnet he's using to influence the outcome of the game, both of which will visualize dilation of the common bile duct. Well, you're kind of confident that your patient's got acute cholangitis. What else should you be thinking about? Let's take a look at some of the diseases that also classically present with fever and upper abdominal pain, and how acute cholangitis differs from each. The first condition on the differential is what you'd probably expect: acute cholecystitis. Right upper quadrant pain? Check. Fever? Check. However, patients with acute cholecystitis should not have a cholestatic pattern, like significantly elevated bilirubin or alk-Phos, on their labs. Additionally, an abdominal ultrasound in acute cholecystitis will show a normal, non-dilated common bile duct, while the gallbladder wall will be thickened. Add to that a sonographic Murphy sign, and you've got pretty much all you need to distinguish cholecystitis from cholangitis. Moving slightly further up, you've got to consider liver disease when your patient comes in with a fever and abdominal pain, especially in the right upper quadrant. Some of the acute liver diseases you might have heard about include liver abscesses and portal vein thrombosis. Fortunately, abdominal imaging is often all you need to differentiate acute liver disease from disease affecting the biliary tree. Look for telltale findings on abdominal ultrasound or CT, like a liver mass or occlusion of the portal vein, to point you away from acute cholangitis and more towards liver pathologies. Finally, let's not forget about the pancreas. Patients with acute pancreatitis often present with both fever and abdominal pain. While the pain of pancreatitis is classically epigastric and radiates to the back, it can't be localized to the right upper quadrant in some patients. One distinguishing feature that acute pancreatitis will produce, however, is an elevation in serum lipase and/or amylase levels. Look for this on labs to point you towards acute pancreatitis and away from cholangitis. All right, let's sum up the presentation of acute cholangitis in a sample assessment statement. Angie C. is a 43-year-old obese woman presenting with fever, nausea, and right upper quadrant pain for the past 2 days. Vital exams are significant for a temp of 39.5 degrees Celsius and heart rate of 99. Physical exam is significant for scleral icterus and right upper quadrant tenderness with guarding. Her labs are significant for a white blood cell count of 16,000 with neutrophil predominance, total bilirubin of 8, direct bilirubin of 5, and alk-Phos of 650. ALT and AST are mildly elevated, while lipase and amylase are within normal limits. Given her lab findings, Angie's presenting symptoms are concerning for acute cholangitis. As we mentioned earlier, acute cholangitis is a medical emergency. Once you make the diagnosis, prompt treatment is required to prevent further badness. As with most conditions in which a sedated procedure might be required, patients with acute cholangitis should be made NPO on admission. Acute cholangitis and septic shock are frequently encountered together, which is why patients with acute cholangitis often require aggressive IV fluid resuscitation. We're talking in the ballpark of 30 milliliters per kilo here. Since acute cholangitis is often associated with septic shock, which often leads to acute kidney injury, IV opioids, rather than NSAIDs, are the first-line choice for pain control in these patients. See that curiously petri dish-shaped red fountain? That's to remind you that while you're putting your admit orders in, collect some blood cultures. In patients with acute cholangitis, Blood cultures help to both diagnose bacteremia and provide useful antibiotic susceptibility data so you can tailor antibiotic therapy. Speaking of which, all patients with acute cholangitis should be started on empiric IV antibiotics, represented by this IV-covered antibiotic pill bottle hat that covers the organisms involved in severe intra-abdominal infections. That often means big gun agents like piperacillin tazobactam, carbapenem, or cefepime and metronidazole. As we saw previously, ERCP is both diagnostic and therapeutic. Specifically, the endoscopist will perform a sphincterotomy, which dilates the outlet of the common bile duct, extract the obstructing gallstone, and drain all that backed up bile, aka biliary decompression. After the episode of acute cholangitis has resolved, patients with gallstones should undergo cholecystectomy to keep it from happening again. To keep elective cholecystectomy on your mind, we've drawn in this scalpel slice papaya on this partygoer's hat? Headpiece? Whatever that thing is. Notice that it doesn't have a rising sun on it like the hat we drew for acute cholecystitis. This is to remind you that cholecystectomy should only be done after acute cholangitis has resolved. All right, let's wrap up with a brief recap of what we've learned. Acute cholecystitis is a clinical syndrome of gallbladder inflammation most commonly caused by gallstone disease. In addition to the classic symptoms of biliary colic, acute cholecystitis is distinguished by the presence of fever. A positive Murphy sign, that is, abrupt catching of the patient's breath on deep inspiration while you palpate the right upper quadrant, is pathognomonic for acute cholecystitis. The only lab abnormality you're likely to see in acute cholecystitis is a leukocytosis with a left shift. Other abnormalities, especially in liver labs like ALT, AST, bilirubin, and ALK-Phos, suggest a different condition as the most likely cause. Abdominal ultrasound is the most common imaging modality used to diagnose acute cholecystitis, with HIDA-scan used if the abdominal ultrasound doesn't cinch the diagnosis. Management of acute cholecystitis includes admitting the patient, making them NPO, giving IV fluids, providing adequate pain control, starting empiric antibiotics, and performing early cholecystectomy within 72 hours of admission. Two special types of cholecystitis deserve a special mention. A calculus cholecystitis, as its name suggests, is not caused by gallstones, but rather gallbladder stasis and ischemia, and typically affects critically ill patients. Emphysematous cholecystitis, on the other hand, is caused by infection of the gallbladder with gas-forming bacteria such as Clostridium perfringens. You'll know it when you see it, because diagnosis involves visualizing gas in the gallbladder wall on imaging. Next up, cholangitis is an inflammatory condition of the bile duct caused by bile stasis and subsequent infection from bacteria ascending from the GI tract. Acute cholangitis typically presents with the clinical syndrome of fever, right upper quadrant pain, and jaundice, aka Charcot's triad. Add on hypotension and altered mental status, and you've got Raynaud's pentad, a marker of severe suppurative cholangitis and a true medical emergency. In addition to leukocytosis, a cholestatic lab pattern is often what differentiates patients with acute cholangitis from those with acute cholecystitis. This means elevated conjugated bilirubin, ALK-Phos, and GGT levels. If you see elevated liver transaminases too, that suggests formation of a liver abscess, a bad complication that's associated with the high mortality rate. The imaging modality of choice for acute cholangitis is ERCP, since it's diagnostic and therapeutic. Speaking of therapy, for acute cholangitis, admit the patient and treat them with NPO status, IV fluid resuscitation, pain control, blood cultures, empiric IV antibiotics, and sphincterotomy with stone removal via ERCP. Once the patient has recovered, go ahead and perform a cholecystectomy if the cholangitis was caused by a lodged gallstone. Thanks for watching. In our third and final sketch in this series, we'll dive into some of the less common conditions affecting the bile ducts. They're rare, but that's why test writers love asking about them.